Good evening and a warm welcome to all the delegates who have joined us today for yet another interesting webinar with WhiteCoats. In today's webinar, we will be covering the topic Lipid Management Guidelines in India, Critical Analysis 2020 by Dr. Sadanand Shetty. We also have Dr. Milind Phadke as a moderator for this webinar. Dr. Sadanand Shetty is a renowned cardiologist with over 30 years of experience. He is an Emeritus Professor, Dr. D.Y. Patil University School of Medicine, Mumbai. Dr. Shetty heads the Department of Cardiology, Somaya Super Specialty Institute, Mumbai. He is Chief Medical Director for Sadanand Healthy Living Center Limited, Mumbai, and also the founder, Sadanand G2S2 Foundation. He's also Editor-in-Chief for Indian version of Cleveland Hall of Fame for Biography and Patient Education book, and founder of CVD India and CA International. Welcome, Dr. Sadanand, sir. We also have Dr. Milind Phadke, Consultant Interventional Cardiologist. He is an Associate Professor in Cardiology at LTM Medical College and LTMG Hospital, Mumbai. Dr. Milind is a gold medalist in DM Cardiology from GS Medical College and KEM Hospital, Mumbai. He has over 40 plus peer-reviewed journals and 6 book chapters to his name. Welcome, doctors, for this interesting webinar. A couple of instructions for all the attendees. Please ensure your internet connectivity is good to have a seamless experience. By default, all the attendees will be on mute and in listen-only mode. Attendees can click on the raise hand option, or you can type in your questions in the chat box, and we will take the Q&A questions at the end of the session. Now, without any further ado, I invite Dr. Sadanand to start the webinar.
Thank you, Jason, and friends. Good evening for our one more webinar. And I must compliment WhiteCoat for giving us this opportunity. And this is our third webinar in the series of webinar what we have planned. As you all know, the first webinar was on management of hypertension in Indian context in 2020. The second one was on diabetic mellitus management in 2020 in India, and after critical analysis of all the available guidelines. So today what I'm going to talk is on the very, very important topic, and there's a lipid management in 2020 and in Indian context, because there's a lot of changes in the guideline when you compare the Indian versus the Western guideline. So for the next 30 minutes or so, I'm going to give you the overview on this topic. It is very difficult to cover up everything, but I'm going to touch upon some of the very, very important practical aspects which every physician who is treating lipid problem in our day-to-day real-world practice. Cardiovascular disease is the most common cause of death for, the overall, if you keep all the causes of the death, and even in diabetes mellitus as well. If you look at this particular slide and you see the causes of death, the percentage, when you see the ischemic heart disease and the other heart disease, they top the list. So also when you look at stroke, which is also vascular disease, and also the diabetes, which is also fairly common as we discussed in our previous webinar. So essentially what we are talking is the disease, cardiovascular disease, which are related to, the common, the etiology, and one of the etiology is the lipid abnormality. So ischemic heart disease, other heart disease are the most common cause of, the death among all the death put together, like whether you talk about cancer, whether you talk about pneumonia and the other disease, etc. Now, the Interheart study is one of the study which is almost reported, by Salim Yusuf 15 years ago, which, tells us that this lipidemia is always a major concern for a cardiovascular event, whether it is a primary prevention or a secondary prevention. Essentially, when we say primary prevention, we define when patients do not have any symptoms and signs of, the vascular disease. That means patient has no vascular symptoms, but after getting a vascular symptom like an acute coronary syndrome or a TIA, etc., we categorize into secondary prevention. Many guideline tells us that the first and the primary and the secondary prevention, the guideline recommendation, etc., is different. But I would like to inform you at the very beginning that we must put a word as a prevention. A word of prevention is better than categorizing as a primary or a secondary prevention. That is my personal take, and many of the international experts also believe that we should aggressively treat all these, the potentially easily treatable disease, and one of them is dyslipidemia. So prevention, whether primary or secondary, should be put under one heading called prevention. So what Salim Yusuf has reported in almost 15 years ago, almost in 15,000 plus patients with a placebo of nearly 15,000 control, and multi-country, 52 country, and the PAR, that means the population attributable risk, as shown here, adjusted for all race. If you look at that, lipid is the most common. If you see the PAR is about 50 with the lipid. And then of course the smoking is the another thing. And then of course the psychosocial, abdominal obesity, hypertension, diabetes, etc. What we are discussing is the lipid today. And all 9 risk factors together is almost PAR, amounting to 90. So 50, the PAR is the population attributable risk is due to the lipid. So lipid, is one of the lipid abnormality is one of the common, the denominator or the common reason for cardiovascular event. Do we have evidences that lowering the LDL is beneficial or increased LDL is bad for the cardiovascular system? If you see this particular, the slide, and see the log linear relationship of the LDL and the event, you go through all the study, right from COVID study or the TNT or HPS study, various studies have shown very clearly as the LDL increases, the risk of the cardiovascular events increases, and as you reduce the LDL level, like here it is given as 60, which is now going down and down, and in the end of our presentation you realize there are some situations where you want to get the LDL even as low as 30. There are some individual or a particular high risk individual where we have to get down further low down. So lower the LDL is the way forward. That's the way forward, and that's what is the important thing we must remember at the very beginning of our presentation. Of course, not in everyone, but in a very high risk or extremely high risk case, which we will discuss in our course of time. Is it a growing concern for India? Yes, dyslipidemia is a growing concern for India. 25 to 30% of urban population, 15 to 20% rural subjects are suffering from dyslipidemia. Mind you, the difference between the urban and the rural is, coming narrow now in all the disease lifestyle, whether it's the hypertension, diabetes, even in dyslipidemia, the story is the same, that the gap is reducing. That means in the rural subjects also, this is a growing concern. More common in male, but it also affects both the genders. And 30 to 40 years is the age group that tendency to have a high prevalence. And above 60 also it becomes markedly high. But this is a group what we are interested in, because ultimately what we are seeing in our part of the world is the younger age of this particular growing concern. Not only in dyslipidemia, as we discussed earlier, even diabetes, pre-diabetes, hypertension. In this age group is one which is prone or which is growing concern. So also dyslipidemia is growing concern for us in the younger age group with high prevalence. And if you look at various studies which is done in India, again giving us a rough prevalence of roughly about 25 to 30% in urban and about 15 to 20% in rural subjects. Now there is one study which is very popular one, ICMR INDAB study, which particular study has shown the different pattern of dyslipidemia in India. Now it is also shown in the slide, in the study, 8 out of 10 are dyslipidemic, 80% of young adults, as I mentioned, are dyslipidemic. In India, 9 out of 10 diabetes are dyslipidemic. And if you look at the study findings, the low HDL is one of the important finding in our study, like ICMR INDAB study. High triglyceride about 30%, hypercholesterol may about 14%, and high LDL, particularly the The classical, the Western pattern is only seen in 12%. So our problem is the low HDL, high triglyceride, and increase the amount of what is called the small dense LDL, which is a typical of triad of dyslipidemia in India. Mind you, we are not using the word hyperlipidemia. It is a dysmetabolism of the lipid. We have situation wherein the lipid may not be grossly high lipid level like cholesterol, etc. But there is a dysmetabolism of the lipid system. So we call as a dyslipidemia. Like in diabetes, I mentioned dysglycemia, that is the dysmetabolism of the glucose. Also here, lipid metabolism, which is dysmetabolism. Therefore, we call it as the dyslipidemias. Now let us look at the various guidelines what is available to us. AHA 2018 guideline for dyslipidemia, which is like here this particular slide showing for the secondary prevention. And when you see here, if patient has got a clinical atherosclerotic cardiovascular disease, I said in the beginning, whenever you have a patient who has some clinical evidence of atherosclerotic cardiovascular disease, they come in secondary prevention. One who do not have clinical come in the primary prevention. But unfortunately, to detect ACVD clinical, by symptomatology alone is, not very clear according to me, because we do see many patients who do not have a clinical evidence, but already got atherosclerotic cardiovascular disease, some surrogate marker or indirect indication that there is a atherosclerosis already set in. So it is better we use as a preventive, as a prevention, as a better way of, putting the guideline. But just to discuss of the AHA 2018, as mentioned very clearly, of course, the healthy lifestyle, and then comes the very high risk and not very high risk. And essentially, the American guideline have gone to what is called the high intensity or moderate intensity or a low intensity statin dose. And that is what is in 2018 guideline, basically telling us that you go according to the risk of the individual. And that is because according to the randomized trial, they have shown they have not gone to the particularly the target, but they've gone to the indication like when the LDL is more than 190, when diabetes patient between 40 to 75, and who has got it's an indication for moderate intensity statin, or a diabetes mellitus between age of 40 to 75, and risk assessment to consider high intensity. If he has got multiple risk factors, then again is a high intensity. So basically they have gone by high intensity, moderate intensity, and low intensity. What do you mean by that? We will discuss in the course of time. Also in the primary prevention, they divided the age group between 0 to 19, which is essentially familial hypercholesterolemia or with a strong family history. Between 20 to 39, again, like a strong family history, and again, familial hypercholesterolemia, particularly heterozygous. And then of course, beyond age of 40 to 75, particularly the classical risk factor like a diabetes or a smoking, hypertension, etc. So basically in 2018, along with this particular risk factor analysis, few things they have given us what is called the risk enhancers. And this has got an important relevance, which we are going to discuss during our Indian guideline discussion. But basically the ethnicity one we have to remember, South Asian ancestry is a risk enhancer. And then also the metabolic syndrome again is common in our setting. Also people with the inflammatory disease like psoriasis, rheumatoid arthritis, HIVs have got, they have a high risk for, vascular disease. Then, conditions specific to women like preeclampsia, premature menopause, these are important. Even the persistently elevated triglyceride is important, what is mentioned in 2018. Till 2018, triglyceride was not very well the aggressively reported by the American guideline. But in 2018, this persistent high triglyceride is given importance. So also some, the non-conventional risk factor, HSCRP, LPA, which is important, which we are going to discuss during our Indian guideline. And then of course, FOB and the ankle brachial index. These all tells us some indirect or a subclinical marker of atherosclerosis and easy to follow. So essentially, when you talk about the American guideline, one, they stratify the risk, and second, some risk enhancer, and the risk stratification like less than 5% or more than 20%, in between 5 to 7.5, 7.5 and 20. Then depending upon the risk, very low intensity statin moderate intensity, or a very high intensity statin. Low intensity means 30% LDL reduction, and between 30 to 50 is the intermediate or a moderate intensity, and more than 50% is the high intensity statin dose. That's a statin dose when we say low intensity, moderate, or high intensity. Now, application of the atherosclerotic cardiovascular risk scoring in Indian patients, like alcohol intake, lack of fruits and vegetable in diet, high BMI. These are the few things which have been also shown by the Salim Yusuf study of Interart study, which again gives us very clear indication. See the hazard ratio when you talk about the alcohol consumption, when you talk about whether you're talking about regular drinker or the occasional drinker. And so also if you look at the BMI, which is, for us little on the lower side, unlike the Western counterpart, like we call it as obese moment, it is about more than 19 point, the prevalence is 19.9, and our cutoff of about 22.5 or so is the BMI, which we consider as the upper normal. And then, we take it as, the abnormal. And this is what is the hazard ratio, what is shown in this particular slide. So Indian population, high atherosclerotic cardiovascular risk score was associated with high CV risk features. So this is one where AHA 2018 has given recommendation for primary severe hypercholesterolemia, which is essentially comes to when the LDL is more than 190, which is an indirect indication of something like a familial hypercholesterolemia. And that part we will discuss when it comes to come to our Indian guideline. Now let us look at the ESC 2000 guideline for dyslipidemia management. Changes in the recommendation 2019, one is the lipid analysis for CVD risk estimation. So one recommendation which they gave us in 2019 is on ApoB analysis for risk assessment, particularly in people with high TG, diabetes, obesity, or metabolic syndrome, or a very low LDL-C. This is very, very relevant for us. Now, surrogate marker of ApoB, as shown here, is a non-HDL-C. Calculate the total cholesterol and then minus the HDL, you get what is called as the non-HDL cholesterol, which is again seen in ITG, diabetes, obesity, or a metabolic syndrome. So ApoB analysis is a little costly and it requires fasting, etc. Whereas the non-HDL is a poor man's ApoB, is a cheap and is very easy to do. Estimate the total cholesterol, do the HDL. So subtract HDL from the total cholesterol, you get the non-HDL. And that's an important, change in the lipid analysis, which has been mentioned in 2019 guideline of the European guideline. So change in the recommendation, pharmacological treatment for dyslipidemia, again, statin, ezetimibe, and PCSK inhibitor. We will discuss in detail in the course of time. Also, there is a recommendation to start therapy for triglyceride, which has been some of the, additional recommendation what 2019 European guidelines have given us. So importantly, statin ezetimibe is one important addition in 2019. And if it is not achieved, then adding PCSK inhibitor, and not to take triglyceride elevation, lightly, but also start, treating triglyceride, particularly in a high-risk individual, where, beyond the statin treatment, we have to start, interacting or treating high triglyceride. Unlike in the previous guideline, as I mentioned, the American guideline, the TG were not given that much importance, and that is an important additional or a change in the recommendation in 2019, the guideline of the European guideline. Now, how the algorithm of treatment again go by risk, like, score less than 1, or when the score is more than 10, very high, moderate risk. And that part we will discuss during our time, during our discussion, our Indian guideline. But essentially, again, European guideline highlights the fact, one, risk stratify, low risk, moderate, high risk, or very high. Getting the cholesterol level, as by statin plus ezetimibe, if required PCSK, and doing ApoB or non-HDL cholesterol, and not to take triglyceride lightly when it is more than 200, and when patient is already on statin, in spite of statin, the triglyceride has not reduced. These are the important, the additional, the thing what ESC in 2019 gave us. The other important thing in very high risk patient, they have come to the level of less than 55 as the LDL level. So in secondary prevention and some primary prevention for a very high risk individual, there is a recommendation to get the LDL less than 55. That is one additional the recommendation given by ESC 2019 of intensive reduction of LDL, unlike the previous guideline where they mentioned 70. Now let us look at the Indian, where even we have gone less than 55 also. That we'll discuss in in our corresponding one. The same thing, high intensity statin, maximize the dose. If it's still not ezetimibe, and if it is still not PCSK inhibitor, that's an essential recommendation of the European guideline. Same, the algorithm treatment is more or less the same, and the detail we'll discuss during our Indian guideline. Essentially, what I'm trying to give you the analysis of Western guideline, how the approach of lipid therapy is changing, like how they were earlier and how now in 2019. For example, here I mentioned earlier intensity of the lipid lowering treatment. A moderate intensity is like a 30%. High intensity is about 50%. High intensity statin plus ezetimibe reduces LDL by about 65. PCSK inhibitor alone 60%. PCSK with high intensity reduces LDL by 75%. And PCSK plus high statin plus ezetimibe 85%. So we have to look at what is the LDL reduction you expect or want from the baseline. If you want less than or around 30%, use moderate intensity. If you want 50%, you use high intensity. If you want 65%, add ezetimibe, and so on. So essentially, you go. It's a simple mathematical application of the dose, etc., and the type of combination of the medicine. Like typically, what I mentioned in diabetes and in hypertension is a typical, the application of simple mathematics in our practice. So now let us come to the NICE guideline, how the modification of therapy in the NICE guideline came. Essentially, again, going into the risk stratification is the most important thing, and what is the lifestyle change is another important thing. Primary, secondary prevention, etc., statin intolerance, which we'll discuss in our course of time. So essentially, they have touched upon the principle of starting statin. After assessing the risk, what they're doing is a Q-risk2 assessment tool, and they've suggested 20 milligram atorvastatin for primary prevention, and people with diabetes, both type 1, type 2, CKD, and if ezetimibe, the statin is not enough to reduce, add ezetimibe, or if statin is not tolerable at all, for a primary prevention, there is a provision to use ezetimibe monotherapy also. Though it reduces about 15 to 20% LDL, but it is still better than not giving any drugs. Secondary prevention, again coming to the the standard recommendation of high dose statin, then ezetimibe, and then PCSK, which is going in terms with the other guideline. Now let us look at the Canadian the guideline. Again, giving an idea, the risk assessment, stratification, and the treatment consideration, going essentially by the risk assessment, which is again what I said earlier. What they are, we will discuss during our Indian guideline, because I kept all those the point during the end of our towards the end of my talk, so that you will have very clear, because each guideline, if I go according to their treatment, the risk, etc., we will be confused. So now here in the Canadian guideline, statin is indicated clinical atherosclerosis, abdominal aortic aneurysm, diabetes mellitus, beyond 40 years age, more than 15 years duration, age more than or equal to 30 with microvascular complication, CKD, LDLC more than 5, which is almost like a more than 190. So these are the clear-cut indication. There is a primary indication, again high risk or intermediate risk. Recommendation again goes with the other guideline, suggesting that risk factor calculation is the way forward. So what we are ultimately, all the guidelines so far tells us whether a primary and the secondary prevention, consider depending upon the high, intermediate, or low risk, and what target we have to reach, depending upon the risk factor, and different, like LDL, what is the target, FOB, what is the target, or a non-HDL, what is the target. FOB normally, we don't estimate, so we go more by non-HDL. And then of course, we want LDL more than 50%, at least minimum reduction. At least we must try to aim for more than 50% reduction of the LDL from the baseline. Non-statin treatment, again, like things like ezetimibe I mentioned, which is possible. Niacin, nicotinic acid, they don't recommend. And, fibrate, they don't recommend. But there is, as I said, American guideline and even the European guideline do mention more to it. And in patient who is already on statin, if the triglyceride is an high-risk individual, we have to start using that. But, again, each guideline is little different. So probably Canadian guideline, tells us that possibly they won't involve that too much. Now let us come to our Lipid Association of the, the Indian guide, the Lipid Association India guideline on the management of dyslipidemia. This is the part 1, part 2, and now it is in under print now. We are part of this part 3, the proposed LDL cholesterol guideline. Here, the expert consensus, and here we have a proposed low density lipoprotein LDL cholesterol goal for secondary prevention and the familial hypercholesterol in India with focus on PCSK. And this is the expert consensus, which is going to be, shortly released, and that's a 2020. And we are one of the expert in that particular consensus. And this is what, the relative risk for acute MI in a different ethnic group. As I showed in the initial slide where, the Salim Yusuf study of Interart, how, the ethnic is important. And if you look at, the South Asians as against other ethnic, European, Chinese, and the Latin, we, South Asian, like if you look at all the different, the various lipid measure, and you see almost 40 to 50% of population suffering from dyslipidemia in India, and it is growing concern, nearly 50% of population. And look at, in various, the lipid measures, and look at the hazard ratio, it is clearly more than the other ethnic. So our South Asian ethnic, particularly Indian ethnic, is important for various lipid measure abnormality for getting, the risk of, relative risk of getting acute MI. And we again calculate the risk stratification based on the atherosclerotic cardiovascular disease. And these are the various, like, the risk factor, what we go by, like, more than or equal to 3 major atherosclerotic cardiovascular risk factors: diabetes, CKD, familial hypercholesterolemia, or, the extremely high risk like LDL more than 190, strong family history, even one single risk factor is extremely important, like a heavy smoker, moderate risk where 5 to 15% risk, or a low risk less than 5%. This, we will show one of the risk, how calculate, Milind will show in one of the slide how exactly we calculate the risk in during our QA session. Now, if you look at here, major risk factor as shown here, age equal to more than 45 years in male and equal to more than 55 in female, family history of premature disease, current cigarette smoking or tobacco use, high blood pressure, low HDL-C. These are the major. And if you look at the moderate risk but non-conventional, like coronary calcium more than 100, increased carotid intima media thickness, lipoprotein, more than 50. Remember, lipoprotein is an important problem. Again, lipoprotein A, LPA, is important for us South Asian Indians, and it is 10 times the atherogenic risk as against with a normal level of LPA. Like diabetes is 4 times risky, whereas LPA is 10 times is more atherogenic in an individual. Metabolic syndrome, FOB level, HRCRP, these are some of the non-conventional. And then of course the high risk feature like diabetes with one or the other major atherosclerotic cardiovascular risk factor, what I showed here, and CKD, familial hypercholesterolemia, extreme of a single risk factor, as I mentioned, LDL by itself more than 190, coronary calcium score equal to more than 300, non-stenotic carotid plaque, LPA is equal to more than 50. These are some of the high risk features. And then calculate low risk, is less than lifetime CVD is less than 30. Moderate is, about less than 30. This is, equal to more than 30. Whereas here, if you see the high risk, Again, you see all these various risk factors, very high risk factors. And then this is a new addition in 2020 called extremely high risk. These are category A and category B. Here we have patient with a CAD with equal to more than one feature of the high risk group. That means the 3 major atherosclerotic cardiovascular risk or 2 major atherosclerotic cardiovascular risk with equal to more than one moderate risk non-conventional risk factor. So essentially, these 3 particular features like major, high risk feature and a moderate non-conventional risk factor. This accounts for calculation of these various risks, and accordingly they are categorized into one of the group. And extreme risk is, this one category A I mentioned, and category B, people with a CAD with equal to or more than one feature of very high risk group or recurrent ACS within 1 year despite LDL is less than 50. So we do see patient who is already on maximum therapy, but in spite of that, within short term, like say less than 1 year, they get a recurrent ACS event. So possibly in those patients, we are suggesting that the LDL should be less than 30. This is what is one of the category, which is the new finding, what we are giving for our Indian patient. Now, if you look at here again, lifetime risk less than 15 is a low risk here. Moderate is 15 to 30% is the from the age of 20, and this is moderately high 30 to 44, and the high risk is where you talk about more than 45. This is how the risk and if you look at here, this is what I mentioned. In a case of low risk and moderate, less than 100 is the target treatment goal, and non-HDL is 30 milligram in addition to LDL. So 130, anything 100, 130. Here low and the moderate, what target we require is this level to reach LDL and the non-HDL cholesterol. And what is the recommended drug therapy we start when it is more than 90. So we have to keep all patients less than, like this is the level what we recommend in a low risk and a moderate. High risk less than 70, very high risk 50. And these are the 2 things which are coming up now. The extreme risk factors are the new things what we have to understand in 2020, that these are the 2 important categories as I showed in my previous slide. And we have an option of even coming to less than 30 in a patient with an extremely high risk category, and even in category B, where almost, we must get the LDL as low as possible to minimize or to prevent the recurrent vascular event. Otherwise, patient in spite of our maximum therapy. And this exactly what I mentioned, and basically lifestyle therapy, statin therapy, ezetimibe therapy, and lastly is the PCSK. That is, the therapy which is for, very, very extremely high risk patient. So essentially the therapy boils down to using statin, various dose coming to the high maximum dose of 80 milligram atorvastatin or 40 milligram rosuvastatin, adding 10 milligram ezetimibe. In spite of that, if it doesn't come under control, then we have a addition of PCSK inhibitor, where to get the LDL less than 70, rather less than 50. And here, as I said, the extremely high risk category 2 category, where we can get the LDL to less than 30, which is acceptable. And this is the LDL or the LAI, Lipid Association of India 2020 consensus statement on extremely high CV risk group. That means the category A and B, what I showed in my previous slide, which is the same thing, suggesting that even if you go up to 30, it is fine. And that is what in a very high risk group, about 50, and an extremely high risk category, maybe going down to even 30, is a current, the approach, what is recommended by Lipid Association of India. This is what, like high intensity statin and adding ezetimibe. If still, it is not reached, then you add PCSK inhibitor. They're the monoclonal antibodies. Of course, healthy diet, regular exercise, therapeutic lifestyle we need to follow. Quit smoking, alcohol restriction, etc. is a must to, achieve this type of level. Drug alone is not, is enough to reduce. We have to have aggressive therapeutic lifestyle measures to, the complement the therapy for pharmacotherapy. This is the other important thing what I mentioned, non-HDL cholesterol Why non-HDL is important marker than LDL? Like this is a marker of, the ApoB, because when you look at a plasma lipoprotein, we have various lipoprotein. Now, if you look here, chylomicrons are remnant, they have a ApoB 48. Then we have ApoB 100. These four things are ApoB. This is all ApoB. Then ApoA1 is the HDL. When you look at the LDL, part of ApoB, ideal intermittent density lipoprotein is a part of ApoB, and VLDL is a part of ApoB. So when you calculate all these things, they calculate what is called as the atherogenic triglyceride rich lipoprotein. They are all rich of TG rich lipoprotein because of the ApoB. And when you look at the LDL-C, it is only measure of this. We don't measure LPA separately. We don't measure VLDL separately. So what we do the total cholesterol and remove the HDL. Then what you get is a non-HDL. That is what is shown here. And non-HDL is an important parameter. So in 2020, in addition to LDL level, target non-HDL as a co-primary target. Remember, if difference between the LDL and non-HDL is more than 30, start suspecting that these remnant rich particle, this triglyceride rich remnant lipoproteins are the cause of the problem, and we have to aggressively try to reduce non-HDL than the LDL. And also when you got LPA is high, get the LDL low down as low as possible, because we don't have any specific medicine for LPA. Only recommendation to get the LDL as low as possible. If you have got LPA more than 50, get the LDL to 50, 45, and that will reduce the effect of LPA in the circulation. Otherwise, mind you, LPA is highly atherogenic. The dangerous, the molecule for us is LPA. It is 10 times more atherogenic than even diabetes. We take diabetes seriously just 4 times. But LPA is important thing for us, and therefore again, getting the LDL and getting the non-HDL in such patient. HDL improvement, whatever method we have, we don't have too much of pharmacotherapy currently. But again, getting the LDL down, getting the non-HDL down will relatively help in, even if the HDL is low, the effect on atherosclerosis is blunted. So basically, in a patient of an HDL low, our aim is to get the LDL and get the non-HDL as low as possible, so that the effect of low HDL, like effect of high LPA, is minimized. And that is one of the approach, and that is one of the therapy. And also when you are trying to reduce the VLDL and IDL ApoB, the HDL improves. We have studies which shows us that drugs which are like a fibrates, drug like the saroglitazole, they do improve the HDL by affecting the VLDL or the triglyceride rich lipoproteins. That part probably we can discuss during our question answer session. This is again, high triglyceride is a concern for us. Mind you, Western guideline now started giving importance, like as I showed, AHA 2018, European 2019 guideline, and now ITG, they are suggesting that it is important. For us, India, we have been, mentioning and treating ITG for a long time, but now it is, quite accepted. And mind you, TG is a concern for us. And don't take, triglyceride high, lightly. We have to get the triglyceride also down. So now we have got a clear-cut outcome study on TG, though these are the old study which has, tortured the data, because, they have not got, because they have started using fenofibrate when the TG baseline is low. They are not the cases where we have to use fenofibrate. We have to use when the baseline is more than 200. So here, the study itself, has got a flaw, but even then, secondary analysis, secondary endpoint, subgroup analysis has shown, almost about 30% relative risk reduction. Now, REDUCE-IT trial is the latest trial, the 2019, where baseline TG was 216, and by reducing the TG, and they have used omega-3 fatty acid, that is icosapent ethyl, that is fish oil, which is omega-3 fatty acid in 4-gram dose, and they have shown the mortality benefits, CV death, MI, and the stroke, and that's the first outcome trial of lowering the TG. Of course, we have been mentioning about TG lowering, but they are now mentioning of TG lowering by omega-3 acid. not by the other agent like fenofibrate and saroglitazole, or I don't know why, but basically that's a food for thought for us that at least triglyceride lowering is important. So now Westerners have started believing using this, but only thing is the cost is one important barrier, but otherwise this is available, but it's a high cost and 4-gram dose is quite a steep dose. They're the few limiting. And also the critical importance of ITG is mentioned by ESC guideline, as I mentioned earlier, is almost 2AB. That means the TGs are given importance now, even the Western guideline. And ESC 2019 recommends that TG lowering is important along with the statin when even TG is more than 135. So that's an important thing which you must remember. Now let us come to a few of the last slide. Now why we need low LDL in India? Despite the ACC European guidelines, CV mortality has increased in India by 40%, whereas it decreased by more than 50% in the European and the American guidelines. So we need different guidelines than the Western, because there this is fine, but for us this guideline has not helped because we have still it is increased by 41%. We develop heart disease 10 years earlier. I mentioned in my earlier webinar also hypertension 10 years earlier, diabetes 10 years earlier, lipid problem 10 years earlier, heart disease 10 years earlier. So everything is at least a decade earlier, if not more. 25% of those dying of CAD are less than 45. So we have a huge problem in Indian context. This is a major problem we have because we have young people who are dying of all these metabolic or a lifestyle disease like hypertension, diabetes, dyslipidemia. CAD is more severe and high mortality as compared to non-Asian country because we have extensive diffuse small vessel disease. So our mortality is high. Lipid abnormality different from the other ethnic groups. I mentioned lipid abnormality, triad of Indian lipid like high triglyceride, low HDL, and increased amount of small dense LDL. These are the typical triad of Indian dyslipidemia. We have just raised LDL, but that is small raised LDL. That is about again is a small dense LDL. We have a high TG, remnant cholesterol, low HDL because of our high carbohydrate diet and metabolic syndrome. So we have to target these two things. If we don't target this, we are not going to get success in our lipid management. High prevalence of increased LPA, I mentioned that we have to get the LDL as low as possible because LPA is a dangerous, is a deadly molecule for us. High LDL HDL ratio, as I mentioned, ApoB more than ApoA ratio is again as shown in the India Art study is important. Increased small dense LDL particle. Mean LDL-C is 106 in American, 94 in Indian population. We have, recent, the guideline recommend LDL target of less than 55, whereas we in our guideline have shown less than 40 or 30 as the recommendation. That again, because of this, the aggressive lowering of the lipid abnormality. South Asian ethnicity is a risk enhancer in ACC 2000 guideline. Clearly, now this ethnicity has given importance by Western guideline, particularly the ACC 2019, and lowering the LDL-C to less than 30 leads to further reduction of cardiac event, and as shown in all PCSK trial. And we need not worry of getting LDL low and any, the side effect, adverse effect, or effect on the brain, effect in the body, etc. Even if this LDL goes to 30 or 25 ultra low dose, there is no bad effect in the body. Just few words about the statin and diabetes. We must remember the statin can give rise to little diabetes, but this is again is more in people who are predisposed to diabetes. We should screen, their baseline sugar level, A1C before starting statin therapy. Maybe you can monitor once a year and then depending once in 3 years. But basically, people who are destined to get diabetes, pre-diabetic family history people, they are getting diabetes. But otherwise, because of fear of diabetes induced by statin, don't stop using statin. Please use statin. The benefit is 5 times more than the risk of one time of diabetes, which is not very important. Aggressive lifestyle is the way forward. So this is, according to me, is not important, and we have to give, the importance of benefit of statin more than anything. Statin intolerance is again another issue which you have to keep it in mind. It is reported incidence around 10%, but according to me, it is not really very much. True incidence is not known. It is not that common according to me. Routine monitoring of CK is not suggested for recommending the monitoring of CK for statin-induced myopathy. But people with drug-drug interaction, vitamin deficiency, hypothyroidism, other causes which can potentiate statin-induced myopathy, we have to keep it in mind. If at all it comes, you lower the statin dose, reduce the frequency, change to alternative statin, etc. But it's simple to follow. But see that we must maximize the use of using statin. So coming to the last slide, dyslipidemia is always considered a major CV risk factor for cardiovascular disease and should be treated with statin as a first-line agent. LDL target is now revised based on the CV risk category, AHA, ESC, and even Indian guidelines. This is the take what I want for you, whoever is attending my webinar, that get the LDL target depending upon the risk, as I mentioned, risk category and the LDL target. FOB analysis recommended for risk assessment as mentioned by the ESC guideline, because in people with high TG, diabetes, obesity, or a metabolic syndrome, these all four are our problem, Indian ethnicity. So FOB is important for us, but we are going by non-HDL. As shown here, in India, high TG is commonly observed. So we in Lipid Association of India has given non-HDL as important marker more than the LDL, like what is FOB. So FOB for us is like a non-HDL, is a poor man's FOB, because FOB estimation is costly, requires fasting, etc. Non-HDL do not require fasting, it's easy, it is cheap. Just calculate total cholesterol, calculate HDL, minus HDL from total, you get a non-HDL. And as for the LAI, Lipid Association in India, ESC 2019, elevated TG should be treated with a TG lowering agent in high-risk patient. So very, very important point I want to emphasize again and again. Please give importance to elevated TG in our context, Indian context, and it is now substantiated very well by Western guideline, even the ACC and the ESC. Thank you very much for my patient hearing. Maybe we can have a question answer. Maybe Milind can speak now. Yeah. Maybe one of the slide, Jason.
Yes, sir.
Milind can address that, and then and then we can go to the QA. Yeah. Because let me have drink. I will have a little water. Yeah.
Yeah. Yeah. Thank you very much, sir, for as usual a very lucid and concise talk. And within 35-40 minutes or so, you have covered a lot of ground. And I just wanted to add key, because some of the slides mention that you should use an algorithm based on risk scoring. So the Framingham model, the ASCVD calculator is used in the US population or Western population, but there may be some data to suggest that it may not be that representative for the Indian population. There may be some problems. So one score which is recommended is the SCORE score of the ESC. And you can see it on the slide, the criteria which are used to calculate risk. And it's available as a calculator online, so you just have to type in the details of your patient and you get a combined score. We don't estimate risk routinely in our patients. There are some questions also on this, but especially for patients who are intermediate, there are two extremes. Some patients in whom statins are clearly not indicated. Some patients, like say established coronary artery disease or LDL more than 190, in whom statins are clearly indicated. In the patients in between, these risk scores will help risk stratify, so that you don't unnecessarily start statins in patients who don't need them, especially at younger ages. But on the other hand, certain patients who don't obviously look like statin candidates may turn up to have, scores which are on the higher side, and you may give them the benefit of statin therapy. So these kind of scores are very useful, and probably you can use both the scores, but SCORE may be more representative of the Indian population. And Jason, can you show the next slide? So therefore, we have addressed this issue in a small review article, or it's kind of a booklet, quite comprehensive, which we had written for CAD, and now we have published it as a separate booklet. And we have discussed all the traditional Western guidelines, especially the ACC/AHA guidelines of 2018, and we have tried to set them in the Indian context. where we need to differ or where we need separate guidelines, or do we need more research or clarity? Next slide, Jason. Yeah, so this is the document. If any of you feel interested, please let the WhiteCoat people know. This is available as a PDF document and we can arrange to send it to you. So what do you think, sir? What do you think about the scoring system to be used in Indian patients?
Yeah. The type of scoring, what is your recommendation? JBS3 or the NICE, the UK one is better for us because that includes, the Indian ethnicity, because in the particular study group, and even the other history of, metabolic syndrome and the diabetes, family history. I think that will be the better risk calculator. But overall, I think, Milind, what I would, you can go to our
questions.
This one, Jason, we can go. You can stop sharing that. This is what book they can. So basically, I personally feel, Milind, to make things simple, like how we practice in our day to day. When patient comes, just standard thing like, take his history, take his weight, take his BMI, take all the, like a typical, family history we take, history of, smoking, of course, male or sex we come to know, and then, what all various risk factor patient carries. BMI is simple to follow. Even the ankle brachial index we can do, which is not very difficult. And then, you put all the risk, very simple, like you give scoring for like hypertension, diabetes, these all becomes very simple according to me. By and large, for our patients, they are already in a risk category, because moment you say they got a central obesity, metabolic syndrome, they little, BMI is high, and your abdominal girth is high, they already, are in the category of high triglyceride, high maybe your TGs, low HDL, etc. They may have a pre-diabetic or impaired blood sugar. They may have a borderline pressure, etc. So what you are mentioning is true, if you have to really calculate. But if you have to generalize in a community base, I am saying, a simple precaution of taking care by healthy lifestyle, regular exercise, walk, and then, the risk factor control is an easy way. And
that point is very important.
It's
a very important
point. And then, basically giving each time when they come for follow-up, showing them what is their figure like, say your weight was 80, now he has reduced to 75. So you show that parameter, like we do blood sugar regularly.
We should stress more and more on lifestyle.
Exactly.
In fact, the tendency is just to write a prescription for a statin. That's a very lazy way of doing it.
Exactly.
We have to motivate patients to make lifestyle changes.
Exactly. Few days back, Milind, I was attending, Professor Salvador, who has done a lot of study on aspirin, prevention, antiplatelet and all. He was again mentioning he's going back to prevention because he says more than giving antiplatelet, controlling hypertension, controlling diabetes, controlling lipid, go into that aggressively, Don't think, giving antiplatelet for a primary prevention and making a major impact. Just a point to re-emphasize that look into the simple risk factors which are conventional and also, non-conventional depending upon the type of individual. Like, for example, you do one lipid profile once at least, what is called an extended lipid profile, which can give you idea about, LPA also. It can give you little parameters, etc. See, even that also gives you parameter of a CRP. Doing once, estimating, it is not a harmful thing according to me. So
the message that should go out is that we should not just treat the lipid report. We should take the patient in toto and we should
that holds true for all these are, according to me, this is a typical what is called as metabolic syndrome, and therefore metabolic syndrome, these all are part of the syndrome, included like a pre-diabetes, high triglyceride, even high uric acid, even microalbuminuria, your central obesity. These all are are the diagnostic criteria what is given. So it comes like hypertension and diabetes 50%. No, diabetes, the lipid problem is almost more than 50%. hypertension, the lipid tension is again another 30-40%. So we have to basically aggressive lifestyle, and we have to emphasize on the preventive step, and we have to follow basically, according to me, besides, whatever like smoking, tobacco and all, is the three things: hypertension, diabetes and lipid. If you take, the risk of this,
that is why they have been the three first topics of our webinar.
Yeah, and therefore, and therefore, we have to tackle it very early also. The other important concepts are coming up in these three things is a cumulative effect, Like if you have dyslipidemia at the age of 20 and you now diagnose the age of 30, that cumulative damage of the lipid abnormality has already taken place. Now, at the age of 20, you would have started 10 milligram statin. We could have prevented many things happening, Now, if you are starting at the age of 30, 35, where he has already cumulative effect of dyslipidemia has taken place, and now the effect of, this same dose of lipid therapy may not be same as what it was about 10 years ago. So we have to recognize, we have to create an awareness, and we have to diagnose that early, and therefore all these three lifestyle diseases like hypertension, diabetes, dyslipidemia, according to me, are aggressively should be treated. Whatever other therapy are, according to me, like, adding antiplatelet and this, etc., are not that, great benefit than the control of the risk factors. Yeah.
So would you like to take up some of the questions?
Yeah, we can discuss. Yeah, we can discuss some questions. Yeah.
Okay, so there have been a lot of questions about tolerability of statins.
Yeah.
Especially, for example, what would you say are the practical issues? One practical issue I find is the higher dose statins cause a lot of GI upset, like anorexia and constipation and those kind of things. So, one must understand that when 80 mg atorvastatin or 40 mg rosuvastatin, although it is there in the Western guidelines, the tolerability for our patients may not be as good always. So many patients will come back to you really bitterly complaining that, doctor, my appetite is gone, my weight is gone, my GI tract is gone, I don't get good bowel motion. So you have to be a little practical when you use high dose statins or high intensity statins for a longer duration of time. So sometimes one has to de-escalate a little bit. Ideally, yes, one should use 40 mg rosuvastatin in all high risk patients indefinitely. Sometimes it is not possible. So in such cases, don't be afraid of coming down to 20. Monitor their LDL, then maybe you can add something like ezetimibe. But see, the therapy should not make the patient so miserable that he discontinues it. So it's all very well to say that we should go high intensity and moderate intensity, but tolerability, practical issues, it may not be myositis, but GI upset is one of the commonest things that you can get. Mild muscle pains. Patients do get a lot of body aches. Their CPK may not be elevated to that extent. Frank CPK elevations are rare. But one must, and the other thing about statin myositis is that one must always look for factors which exacerbate statin myositis. We very commonly see prescriptions written, say, a total cholesterol level of 230, a triglyceride level of 250, and patient is started on a combination of fenofibrate and statin, maybe 10 mg rosuvastatin. Now, these are the patients who are more likely to get, say, myositis or at least myalgias. So if you're going to use them in combination, really decide what dose you want and really whether the combination is needed. When treatment is recommended for high triglycerides, now that the European Association has also recommended for high-risk patients, please understand it is not in each and every patient. So the moment you see, the common thing that we see in practice is somebody gets a lipid profile, like I mentioned, 250 cholesterol, 270 triglycerides. He started on a combination of atorvastatin or rosuvastatin and fenofibrate. Now that is not the recommendation. The recommendation is very clear. If these patients after optimal statin therapy still have high triglycerides, and these are high risk patients, only then you consider lowering of triglycerides unless the TGs are more than 500. And the molecule that is recommended is not fenofibrate. The molecule that is recommended even in ESC is icosapentail ethyl, so which is an omega-3 fatty acid. So if you want to go by evidence, it is not nowhere in the guidelines is fenofibrate recommended for prevention of cardiovascular risk. So for you are not doing much good, you are just getting the triglyceride number down. What do you think, sir? Nowhere is fenofibrate specifically recommended in the guidelines for lowering triglycerides for risk. Unless, of course, you have very high triglycerides above say 700 or 800.
Possibly, Milind, here I would have a little because now even the triglyceride is given importance as a
No, I agree, but not treatment with fenofibrate.
Yeah, no, we have to basically depending upon the cause, etc. As you mentioned, many times high triglyceride could be secondary causes,
Absolutely.
like uncontrolled diabetes, or you are patient on some other medication,
Absolutely.
or drugs like your the alcohol intake, or a patient not taking exercise, high carbohydrate. Then
Renal
comes,
issues, thyroid
important,
issues.
important thing is the thyroid is important, even the CKD is important. So always, as you mentioned rightly, we should not immediately jump to conclusion that I need a medication. So we have to exclude secondary causes. So also statin do have some triglyceride lowering effect, not very robust, maybe 10% or something like that. So what Western recommendation also now EAC guideline, or for example, even our LAI, Lipid Association of India also now mention, in spite of starting statin, and if the TG is high, particularly, we have to see what is called the diabetic atherogenic dyslipidemia. The advantage is that because, fenofibrate being, like a PPAR, the alpha action, and also partly PPAR gamma effect also, which is of course is more seen with the saroglitazole, they do have a little insulin sensitizing action. They do have a little sugar control, little better, because they are, typically prescribed in a diabetic dyslipidemia because of the high TG, in spite of good control, in spite of weight loss, taking regular exercise, taken, carbocentric diet, we are corrected. In spite of that, if the TG is more than 204 and the HDL more than 34, it's a clear-cut guideline now to add that, because there are, like, see, now if you see Reduce-It trial, where the TG starting point at 216, so
No,
now,
so I'm not
yeah,
debating the need for reducing
so what
the
I'm
molecule is the issue.
No, I agree with you. So the molecule, what, because we have no, see, this omega fatty acid, whatever Vascepa is available now, 4 gram is cost so much. So, the giving that for our type of patient will be difficult. But I personally
So we
feel,
do empirically treat them with fenofibrate, but that is not really evidence-based.
Yeah.
But,
So, but
we have no other choice in most of it.
we have no other choice. But basically, to some extent, the studies on fenofibrate now, whatever 2 studies has showed, field and the the
There is
other
some
one.
limited benefit.
Yeah, the limited, because the starting TG was not very high. We have to select out the case. It is not that we should be ignoring. So what I'm saying.
So why we are discussing this at length is because hypertriglyceridemia is a very common problem we see in clinical practice. So many of the panelists have asked questions about this. So when do you treat triglycerides? It's a big debate going on in cardiology. So you see, even the American guidelines and the European guidelines are different. So we have to be practical. If the overall risk is high, after treating with optimal dose of statins, if you have high triglycerides, treat them. If the patient can afford icosapentaenoic acid, use that. You can also use fenofibrate, maybe probably less evidence-based, but more practical in our scenario. And now saroglitazole has come up, which actually I was going to discuss, which in our diabetic patients sometimes causes just dramatically the triglycerides to melt away. It has very, very pronounced effects on triglycerides. So that's another molecule which is there in our armamentarium. So that is, would you like to, sir, please?
Because saroglitazole, we have almost now 7 years. 7 years we have completed. Just about a couple of weeks back, we had 7-year completion. Very good webinar. At all our experts who are involved in this, and I had like a very distinct sort of benefit, or rather the privilege of launching the product actually in 2013 or so, and in 2015 or so we have published the first large article, large study, almost 3,000 patients, the efficacy and the safety in Indian Heart Journal, and that manuscript we got the best award in the year of Indian Heart Journal, and that basically was to show the efficacy and the safety. And so basically, saroglitazole has a place according to me. And now with this all ACC saying, TG even more than 135 is a risk enhancer. Now, reduced trial is saying, 206 is the starting point to use reduced. Now, ESC guideline says us again 2AB that, if the TG is more than 200, in spite of this, we have to reduce it. And we are now, at least the saroglitazole data, is reasonably good. And moreover, even the DCJ approval now, second indication has come for diabetes also.
So are there any ongoing trials with clinical endpoints of?
Now, I'm just coming to that. So after the your ADD, atherogenic diabetes dyslipidemia, now diabetes is given permission by DCJ recently, because I was one of the person in the DCJ discussion on this topic at Delhi, and now it is approved for diabetes. And the third approval for saroglitazole is in NFLD, non-alcoholic fatty liver disease. We have, the study in Mexico, in the southern, the America, then even in India, even the MRI, even the biopsy study, they're in phase 3 studies for NFLD. They have shown definite regression of all those, early the NASH indication.
There have been some questions on NFLD also.
Therefore, NFLD NASH is a big problem, mind you. That is why we have to use triglyceride lowering as very seriously.
Because even statins are underutilized.
So my viewpoint always, Indian dyslipidemia, like for me, as I mentioned during my talk, just like hypertension and diabetes, is a simple arithmetic. I don't just jump to only LDL. I am very strong proponent of a triple target. That means I target the LDL, I target the TG, and I target the LDL. And I go by simple thing. One is the LDL is one standard. Non-HDL I calculate always. That I give importance. And then I calculate your TG upon HDL ratio. Understand? Na? TG upon HDL ratio gives you clear-cut indication. If it is more than 3.5, it is an indication, a very simple indication of a small dense LDL. That is again. And the fourth calculation, what I do from the lipid profile, total cholesterol minus LDL minus VLDL and minus HDL. That gives me something like, not VLDL. Total cholesterol minus LDL minus HDL. Understood, no? Or total cholesterol minus LDL plus HDL. So put LDL and HDL together, remove that from the total cholesterol. Remaining is, all are your triglyceride remnant. That gives you an indication how much is the VLDL. And roughly cutoff is 20-25. So that again tells you how TG is bad for us. So when I give a therapy, like what statin to use. For example, if non-HDL is a predominant thing, I use more of a rosuvastatin, because non-HDL is a more important component is a TG, and also to some extent, your IDL, etc. So therefore, I use the rosuvastatin, because atorvastatin and rosuvastatin, because hydrophilic is rosuvastatin and lipophilic is atorvastatin, and the non-HDL lowering is better with rosuvastatin. TG is better reduced by your rosuvastatin than atorvastatin. And secondly, it is, like a drug interaction is less, because, it is a CYP2C9 system, rosuvastatin. If you're in a multiple polytherapy, like our cardiac patient, heart failure therapy, rosuvastatin is a minimum drug interaction. And
the other practical point about rosuvastatin is that it has been found that in Asian patients, they have higher blood levels of rosuvastatin.
Exactly.
In fact, if you're planning to use low to intermediate dose, start with 5 milligrams.
In fact, there are, Japanese all, we have 2.5 milligram also available, even 2.5.
In Japanese patients, it's even more.
Yeah, even. Therefore, what I'm trying to say, we have, as you mentioned, basically, I'm not going by 40, 80 as, whatever guidelines, I'm going to go by my target, I'm, both, the dose, the target dose and the target effect,
Are there any other specific situations where you choose one statin over the other? For example, what is the role of pitavastatin according to you?
Yeah, that, again, as you said, it is supposed to have, you know, the little of your diabetes supposed to be neutral with that. In fact,
And
it
it's
is
supposed to be hydrophilic as well.
yeah, it's hydrophilic. It again drug interaction minimum. And the third thing, as you said, there is no diabetes. In fact, it is benefits the diabetic. You know, it is again improve the thing, etc. And again, you know, being drug interaction is minimum. We can give one with a patient who has got little mild liver disease, etc. Maybe NFLD may be a specific indication for that, and things like that. You know, the
Yeah,
other
and pitavastatin is not metabolized much by the liver also.
yeah. So therefore, you know, again, it's supposed to be a little safer. So there are, you know, distinct things, but it's not taken that much big in our routine practice.
So for the benefit of the panelists, one must point out that you know the largest data has accumulated with simvastatin and atorvastatin, followed by rosuvastatin also.
And the other thing about the pitavastatin, you know, in ACS and all, see, in a chronically stable patient, we can switch over. But otherwise, you know, acute coronary syndrome, we don't have a too much indication. No? In heart failure, atorvastatin is supposed to be better than rosuvastatin. No? There are some studies, you know,
So we always have to balance what, you know, the companies say and what is theory versus what is evidence based.
Because
acute coronary syndrome, we would still stick to atorvastatin and rosuvastatin.
Yeah. So basically, acute coronary syndrome, atorvastatin, rosuvastatin, interchangeably you can do. Primary prevention supposed to be more rosuvastatin trial has come, and you know the secondary prevention again more of, you know, all those atorvastatin like that interchangeably we can use. But by and large, we have to go by both the dose and the effect according to me. But what we want is the effect particularly, you know. And as you mentioned, many times, you know, we may start a very high intensity statin dose, and if you repeat, and if it comes down alarmingly low, there is a provision to go down to intermediate intensity, you know.
Absolutely.
So it is not necessarily that every patient, what guideline, once you say 80 milligram atorvastatin, 40 rosuvastatin for every ACS, you know, for 1 year, as you said, some patient may be very sick with the drug and is not able to tolerate the medicine. So that is not a right way of writing prescription according to me, you know. Whatever prescription we are giving, patient should, you know, should able to take that. He should be tolerable, and we also must see that there is no adverse effect, you know, and you know the other drug also should gel with that. Understand? Huh? Drug interaction also should not occur, etc. So we have to basically look individual into multiple, you know, the characteristic patient.
Can you also, sir, tell something about ezetimibe, because there are a lot of questions, because now the ezetimibe has suddenly come up in the guidelines in the last couple of years.
Ezetimibe, unfortunately, I will tell you, Milind, that one study has killed ezetimibe, you know, and now, you know, as you said, after that improve it, and now this, you know, the aggressive lowering of ezetimibe has come back is unfortunate thing that during 5 years, many of our people have stopped using.
It was not available easily.
We have never stopped using that molecule. I never use myself. In fact, one of my most favorite drug is ezetimibe, you know. And mind you, in Asians, in Indians, it is not only 15 to 20%. It can reduce up to 25%. And my one of the most common prescription is 10 milligram of rosuvastatin with, you know, your 10 milligram of ezetimibe is the most common indication in a chronically stable patient, because this is almost equal to 40 milligram rosuvastatin, almost can get down to 50 to 60% LDL from the baseline. So therefore,
so if a patient cannot tolerate higher intermediate dose statins, it is a very good add-on to targets, and now it is recommended also. Now
the other thing what, you know, the delegates also should know, 10 milligram, when you double the dose of statin, the effect is not double. It is just reduces by 6% more, you know, rule of 6. This is also they must remember. Say 10 milligram reduces the LDL by 30%. Now 20 milligram is not 60%. It is just, you know, additional 60%. Another increase, doubling 40 milligram will reduce by another 60%. So doubling of the dose and what is called a rule of 6 is important. Therefore, if you say rosuvastatin reduces 30% by 10 milligram, 40 milligram reduces by 50% only. Understand? Na? So basically, we have to go dose of each drug add with the ezetimibe, that will be better. So suppose if you have to use ezetimibe and rosuvastatin 40 milligram, unfortunately, Indian pharma today, we don't have a combination, which I've suggested all the pharma guys that give us 40 milligram rosuvastatin with 10 milligram of ezetimibe combination. But it is not there. But in all acute coronary syndrome, all post-MI patient, my patient always on ezetimibe plus either Rosua 40 or Atrova 80, mind you. And today we are very, very aggressive in ACS. Now, equation of managing dyslipidemia in ACS is a different topic. In fact, now there is a place to use PCSK injection just before discharge to see that LDL is less than 40. Because the
again, benefit of the audience, PCSK9 inhibitors are newer molecules which are injectable and they
are agreeable. I agree. They are, one of the.
No, I'm just giving an overview because I have got some questions. What is PCSK9? So in case somebody doesn't know. These are used to further reduce LDL to very low levels. And there is data now supporting that in patients post ACS and high risk cardiovascular disease, they significantly reduce cardiac endpoints in terms of along with LDL reduction.
So therefore, basically we have different type of patient depending upon the risk. For example, we have a young patient, you have done an angioplasty. Within, less than 1 year, he comes with another, event in another artery. What are you going to do? So here we have a, indication for every drug. A patient who is established coronary artery disease, we have done surgery. Within a couple of years, he comes back with again recurrent symptoms. Or we have put in a stent, he comes back with a recurrent ISR, or he gets another event in the other artery. So we have to keep their LDL less than 30 or so. This is the point. What I'm trying to say in 2020, if you have to manage the lipid abnormality, don't just get satisfied only with the just LDL of what age old, what we started using statin and what is today. So basically look at individual, look at the patient characteristic, look at a risk factor, look at what, particular, like a low risk, moderate risk, high risk, very high risk and extreme high risk. So today the risk is 5 and in extreme high risk, either category A or B, but I would put both categories as 1 only as getting the LDL to between 30 to 50. So low and the medium around 100, high is about 70, very high is about 50, extremely high risk between 30 to 50, like that. That is a level.
One more question, we'll have to take some questions. A lot of questions on statin therapy and LDL lowering in young people. Over 40, the guidelines are very clear. But often now you have these patients who undergo health checkups or for whatever reason they get their cholesterol levels done. And they get cholesterol. Suppose if you have a 25, 30-year-old gentleman or lady who comes with an elevated LDL. So what are the situations in which you would give statins to them? Because now we are talking about statin therapy for decades together. So what do you think? So I mean, the guidelines say that if these patients have an absolute LDL level of more than 160, and plus they have either a family history or a premature evidence of CAD or some evidence of atherosclerosis, they should be treated with statin. But otherwise, people are very reluctant or hesitant to start statins to people in their 20s, especially if the LDL is not more than 160 or 170. So what are your thoughts similar or do you have a different policy?
No, you are right actually, Milind, but I would personally feel, like this LAI now 2020 in our expert consensus, where I said low risk, moderate risk, the level what is, the recommended to start therapy is 130 as given LDL. Because, as you said, 160 may be the Western guideline, etc. One thing I would personally tell the delegates and what is my take on, the reduction for a primary prevention, we need to be very, very aggressive in LDL lowering. We no more should take it, like LDL lowering is bad, etc. And it is, bad, you should not start therapy, etc. Even now, even the American Pediatric the Association, etc. Even a pediatric age group. Now, if you got, like a familial hypercholesterolemia, don't we start therapy very early, etc. So also, 130 is what is given in our now 2020 expert consensus. again, we can develop on that depending upon, as you said, family history.
I would personally always try to start with lifestyle modifications.
Lifestyle, yeah. Therapeutic, remember,
for a young person, I'm saying.
Remember one thing, therapeutic lifestyle is a cornerstone, young or old, every step. Along with
that is a message which has to go very clearly from this forum, because it's very easy to write a statin prescription. That is what we see many people do. But
along with our therapy of all these diseases, hypertension, diabetes, obesity, metabolic syndrome, lipid abnormality, therapeutic lifestyle, even for us doctors, mind, even for us doctors, physicians, about their own health point of view, therapeutic lifestyle is a way forward for all these things. There's no doubt about it. But to my mind, Milind, therapeutic lifestyle do have some effect. But as I said, we have this, like a genetic predisposition. We have, that, ethnicity problem. We have, that otherwise LPA is why only in our Indians, more than the, even like a Westerners. We have, genetic predisposition of all those abnormality. On the top of that, our lifestyle and the positive calorie balance are the cause. But once you have got this, that inherent, problem in body itself due to the genetic predisposition, therapeutic lifestyle can make, like a 130 can come to 120, 115 or so. I'm not sure that I would like to get LDL by about 100, even a low risk category, even if the risk is less than 5% is, I would, or even the lifetime risk is less than 15.
So my only concern is that we will then end up starting statins in the large segment of our population.
I agree, but what to do, hypertension, we always see.
I'm saying otherwise patients with no risk factors, asymptomatic.
Look here, Milind, in a preventive medicine, if you have to really see, don't we see, even a young patient with a lipid little on the borderline getting an extensive vascular disease, doesn't have diabetes, doesn't have, many other conventional risk factor.
So would you be in favor of more aggressively assessing the risk factors by doing coronary calcium?
Exactly. I am very aggressive guy regarding the preventive medicine. And I would look upon these 3 risk factors very, very aggressively. I would, follow this patient. I would do whatever, besides therapeutic lifestyle, maintaining weight, eating, etc. is fine. But I would categorize and I would start preventive therapy very early. This is our, whether you see hypertension, whether you see diabetes or a lipid abnormality, by the time we recognize this problem, we are 10 years late. And this cumulative effect of this disease, non-communicable disease, are now highlighted. Every now and then we have, this cumulative effect, and this is what, in fact, one of my talk, earlier time in CSI was a pre-dyslipidemia, like you are talking about pre-diabetes, there is a concept like pre-dyslipidemia, that same thing. What you are saying, young people, 2020, is called pre-dyslipidemia, pre-diabetes, pre-hypertension. See, pre-hypertension term, removed by the ACC in the subsequent, best according to me guideline or 2000, the 7 guideline or the JNC 7 guideline, where pre-diabetes, target organ damage, and other comorbid factors were included. A very, very important thing to me, And so also pre-diabetes, pre-dyslipidemia. These all are like cancer. Why we have pre-cancer? It is something like that, Milind. So we have to impress upon our people, and it is a very easy treatment. Don't you think hypertension is easily treatable with 1 or 2 pills?
No, absolutely. I mean, we in high risk individuals, in individuals with certain
dyslipidemia is easily treatable. Don't you think diabetes can be easily treatable? And you can prevent all macrovascular and microvascular complications. Now tell me, at the age of 30, patient suffering coronary artery disease, what would be his long-term, chronic therapy, the cost involved as well as the life, what will the longevity of life, etc.
So that's another problem. Early diagnosis and picking up
very important. In fact, a few days back, I will tell you, we had one American College of Physicians where I was involved in that. There is a hypertensionologist and hypertensionist. And that means, diagnose hypertension time. Now there is a move, and now we have suggested the national board to introduce this particular, one of the subspecialty, hypertensionist or hypertensionologist. And
So
there
here
is,
in India, interventional
yeah,
cardiologists
and
do
yeah,
everything.
and
Probably we
now
need more specialization.
I've also, you know, the highlighted, even the national board chairman was there, and there is a big, you know, need for starting hypertension clinic.
No, absolutely, I agree with you on that
These are
point.
very, very easily preventable disease,
Yeah.
Milind.
We need proper treatment and
Exactly.
control of
And
hypertension.
if you treat these illnesses very easily, and even I tell family physicians also, you know, Babu, keep this patient like, you know, once a week or once in a month, keep all these patients. You can have give some health education talk. You can keep one particular day for all these people. And you can do something like a semi-consultant job, you know, which will be professional also good. You are giving good advice plus good therapy, and also for, you know, your cost of, you know, the professional charges, etc. as a consultant. What additional, you know, a family physician requires to know? You tell me. If he knows the basic therapy of hypertension, basic therapy of lipid abnormality, basic therapy of diabetes, that is enough, you know.
So that has been the message, I think, for the last 3 webinars.
Yeah.
The 3 risk factors which you have to detect on
Yes.
time, manage aggressively. So instead of being aggressive only in interventions, be aggressive in detection and treatment also.
And that is why also we have covered in 2020.
Yeah,
In
correct.
current time, and also Indian context, mind you,
Absolutely.
and review of all guidelines. We have
That
reviewed,
has been the purpose of our
yeah,
webinars.
hypertension, all the guideline we reviewed. Diabetes, all the current guideline we have reviewed. Lipid abnormality, all the current guideline we have reviewed, and Indian context and what is the current way we have to move on, you know.
Absolutely.
So there is no question about the utility of this our webinar, you know, the knowledge sharing. There is no doubt in my mind that we have focused on these topics, because I wanted to finish first these 3 very, very burning and the common topic, and also different viewpoints, you know, like hypertension, what was the viewpoint, what was the viewpoint in diabetes, and what is the viewpoint on lipid, and all this as a cardiovascular diabetology. It is not that we need a separate space, as a one specialty who looks up, you know, all these things. If you have to really prevent cardiovascular disease, according to me, take care of these 3 risk factors properly, you know, I think you can prevent many, you know, the long term. And according to me, all this advanced therapy, what we are doing, angioplasty, bypass, all the other therapy, only less than 5% of a population can afford this. And
I think that is a very good note
and,
to you know,
and particularly for us, you know, Indians, you know, less than 60% below poverty line, a simple 1 or 2, and that's the way the polytherapy concept came in. But here I am saying polytherapy or more whatever therapy based on the risk. It is not that over the counter go and collect medicine and take it. Risk stratified. Anything? I think we have almost 8:30 now. Jason.
I think, sir, we have had a very long discussion.
Jason, I think it is enough now, I feel. Or you want us to go further and further?
It's become
this is a very interesting topic altogether, sir. So,
Yeah.
We have covered most of the questions. I think we have had a
Absolutely.
very thorough discussion. And for some of the questions which I can see, the answers are there in the slides themselves. So one can always go back to the talk and pause at the relevant points and again have a look.
Yeah.
So,
I think we must thank WhiteCoat for giving us this platform. And according to me, this platform and the knowledge sharing in this platform with the type of topic, what you have finished 3 topic, and the next topic, Dr. Milind is going to suggest you, and maybe next date also we will put to our listeners and delegates. And I would like to,
maybe we can have some suggestions.
Suggestion, which, you know, always Jason puts before what they expect from our webinars, and we must compliment our delegates also for, you know, registering in large numbers and attending. I think with this I would, unless Jason you got something to say, or Milind you want to conclude, give some remarks, or you would like?
I think we have been very we have taken up the 3 emerging issues in cardiovascular medicine.
Yeah.
And I think you have done a very thorough job as usual. And I think the delegates have had a wealth of knowledge and experience from you, and I have had the privilege of moderating these sessions. So I have also learned a lot from these sessions, and I think this is a good platform, and we can go ahead with many more such things in the future. I think that is what I would say.
Yeah, we are, and there is some from the chat box, please post the previous videos, So it is
Yes, sir. We will.
They are there on
definitely-
YouTube.
So what it is in the YouTube, but possibly Jason, you can communicate to them, people.
We do email them, sir.
Okay, you email them so that because maybe
So they can just go to YouTube, and if they give a search of WhiteCoat webinars, they will get
Yeah.
all the webinars. That's
Yeah.
all they have to do.
Okay.
Yeah.
Okay. Thank you, Jason.
So-
Thank you,
Yes,
Milind.
sir. So
Okay.
with this talk, sir, we have come to an end of this engaging webinar. And sir, I sincerely thank you and Dr. Milind for discussing an important topic today on the lipid management. Just to summarize the webinar, sir, so we had an elaborate discussion on dyslipidemia guidelines, guidelines on primary prevention of CVD, dyslipidemia management, treatment algorithms, role of statin in primary and secondary preventions, and many other interesting topics within this topic, sir. So also an interesting set of questions from doctors, and I'd express my gratitude, sir, for listing out and then answering them very patiently. A note to the delegates, presentation of this webinar along with the video recording will be shared over an email in a couple of days. And as rightly mentioned by Dr. Sadanand, please tune in for more updates on future webinars and share with us what topics would you like to listen from our speakers. With this, we come to an end, and I thank all the delegates for a wonderful participation for this interesting webinar.
Thank
Good
you.
evening and have a great day.
Thank you, Jason. Thank you, Milind.
Thank you.
Thank you, sir.
Thank you. Bye.
Jason. Thank you.
Okay. Bye.
Bye.